in order for you to have a better understanding of the disorders, you have to know the normal function. So when we talk about how bones grow, long bones grow in length. So we know we have our metaphysis and diaphysis of the bones that allow for bone growth, and then separation of the epiphyseal growth plate ruptures the blood vessels that nourish those growth plates. So if you have trauma of the bone and it cracks the growth plate while you're still of age to be growing, for those long bones to grow, it can cause the bones to stop growing. So that's why it's so important, especially when you're talking about pediatric patients who have wrist fractures and lower extremity trauma, that we get good x-rays to see if the epiphyseal plates have been ruptured or have been broken or cracked, so that we know whether or not it's still getting good blood flow. Because if the blood flow stops, then the arm doesn't grow anymore. And so then the child grows up with one arm that's continuing to grow and another arm that's shorter, that's still the size it was, or stops growing. And so it's still the size it was during childhood before the fracture. All right. So we talk about torsional deformities. What are torsional deformities? What does your textbook say about torsional deformities? What is it? Does anybody know? Twisting. Torsion means twisting. So torsional deformities are basically where the long bones of the lower extremities are rotated in the wrong direction. So they can be rotated inward, and your patient will have their toes pointed in, or they could rotate outward at the hip, and then the toes are pointed out. And that can happen at the hip, or it can happen at the tibia. But basically, when those bones come together, when those bones form, they form twisted or in an abnormal position, which leads to the toes pointing in, so being pigeon-toed, or the toes pointing out, which my grandmother used to call wane-footed. I don't know what they call it here, but in North Carolina they call it wane-footed. Typically, it happens during the growth period. So sometimes you'll see it as the long bones grow, they twist more. Um, and it can also happen in infants because infants are growing rapidly. So these happen during normal growth periods a lot of times. We'll start to see the twisting happen. It can happen during the fetal stage as well, but it becomes more pronounced as the child grows and as those bones get larger. And again, it can happen at the femoral joint, and it can also happen at the tibial joint. So if you think about how things are connected, so the femur connects into the pelvic bone, and I'm talking with my hands and y'all can't even see me, but the femur connects into I'm going to turn my camera on. I just can't do this. So the femur connects into the pelvis, right? So these are our femoral heads right here, and they kind of rotate around inside the pelvis. So your pelvis is here. So we've got a pelvic bone, and then we've got the femur that kind of fits inside it. Well, if our femurs, so remember, these are connected with tendons. There's tendons, ligaments, and muscles that are connecting all around this femur. So if it starts to rotate in, what happens to those muscles, tendons, and ligaments that are holding things in place? Are they in a normal position? So our femur's here, it's supposed to be here, and then it rotates this way. No, so our muscles, they begin to stretch. Exactly. So that leads to, as Stanley said, tightness as the person gets older. Those tendons get stretched and tight so that the person will actually start to have back pain, and pain that starts in the back and radiates all the way down to the legs, or can radiate all the way down to the legs because of the abnormal positioning of the bones, which is causing an abnormal position of the muscles as well. So these people can have hip pain, they can have chronic knee pain, especially if the twisting is at the tibia. Then they tend to have knee pain as well, as those ligaments stretch. And you could think, if you think about how the knee forms, so we've got our tibia here, and then our patella is on top. So if your patella is on top and it's being held down by those ligaments, your your patellar tendon, your ACL, your MCL, your LCL are all in here holding this joint together and holding these things in place. If the tibia starts to twist one way or the other, that patella is not as stable. So it's a much easier for them to dislocate their patella as well. And then many of them will also have foot pain, and particularly can develop plantar fasciitis because all of those tendons and ligaments and muscles are tight. And so it pulls on the patellar tendon as well and can cause plantar fasciitis. Now, what's genu varum and genu valgum? What are those? So torsion is twisting, right? So our femur twists or our tibia twists abnormally, right? So that forces the toes in, or it can force the toes out. What's genu varum? Genu varum is bow-legged. So now we have a rounding of the bones that causes the knees to kind of come out in a half circle. If it's very pronounced, can be, up to like a half circle type of formation. And then what's genu valgum? Valgum. Genu valgum. Knock-kneed, exactly. So when I'm going to try and pull up a picture of the musculoskeletal system. Bear with me for just a second. I'm going to try and change our picture. So genu varum is bow-legged and genu valgum is knock-kneed. So what's the concern? Is there a concern? Should we be worried about these patients who have genu varum or genu valgum? Is there a concern, you think? So it can affect their mobility, exactly. So let's look at how everything's attached. So we have the bone structures on this side, and then we have the muscular structures on this side. So they can have it's usually not bone pain, it's typically muscle pain. So let's look at this. So for our torsion, so you see how the head of the femur, the acetabulum, you all remember that term, acetabulum, fits into the pelvis. So the femur comes down and attaches here and connects to the tibia, which comes down and connects to the foot. So if that femur, so this piece rotates forward, can you see how all of these muscles that are attached would stretch anteriorly? So if the femur twists anteriorly, do you see how all of these muscles would have to stretch anteriorly as well? And then the groin muscles would be shortened. Do you see that? Does that make sense? Exactly. Okay, so with the shortening of the groin, that increases the risk for injury from pulling or stretching the groin, and it also increases the risk for pain. So it increases the risk for injury and increases the risk for back pain. So if we anteriorly rotate all of these muscles are connected to the back muscles, the lower back muscles. So the lower back muscles are stretched, which means that there's a lot more tension, so they have lower back pain as well. And so if you think about how everything is connected, you can see how if we rotate this femur, it's also going to cause a rotation of the knee as well as the foot. So that's where you get your pigeon-toed from. If we rotate the acetabulum backwards, so we take this trochanter and we kind of push it back and rotate it back, you see how the groin muscles would be stretched, but the back muscles would be shortened. So then that could cause decreased mobility in the hips and in the lower back, which then rotates the knee outward and rotates the foot outward, where you get your wane-footed from. And so then the abnormality with genu valgum and genu varum is more here towards the knee, and it's more of a rotation or it's an outward push of the knee for the genu varum, or an inward push, not a rotation, but more of a, if I take this patellar, this joint here, and I kind of pull it out and create a semicircle, that's our genu varum. Or we kind of push these in, which can also happen because of an abnormality with the hip joint. So the hip, the acetabulum is rotated up and in, so then it leads to genu valgum. And the way that I remember the difference is because, and this is probably going to sound silly, but when you look at the way that the word is written, R and U are both rounded, and the L and the G kind of come together in the format of the knock knees. So that's how I remember. The L and the G come together like the knees do, and the R and the U are rounded. So that's how I remember. And then flat-footed. So what does flat-footed mean? We say it a lot, especially in sports. You have people who can't run very well, and you say, oh, he's so flat-footed. What does that mean? So the arch kind of falls. So they don't have a super high arch. All of the muscles on the side of their foot, this big arch that is helped to be supported by all of these muscles and tendons and bones in here, kind of falls. And so sometimes what happens, and let me pull my picture back up. Let me pull my picture back up. My boys are on their way to basketball practice. All right. So sometimes it's not just that the arch is falling. Oftentimes the problem is more with the this joint here. So these muscles here kind of pull inward, and so the patient is kind of walking on the inside of their foot. So all of these inner muscles here are stretched downward so that the patient kind of walks on the inside of their foot, and they don't have an arch at all. They lose that support from the tendons, the ligaments, and the muscles. And so those muscles that are supposed to keep that foot level kind of loosen, and the foot kind of rotates, and so they lose their arch. Then we have other limb deformities. Syndactyly is when you have webbing of your fingers and toes, which can happen in humans. And then we also have polydactyly, which is having an extra digit. So if you're born with a sixth finger or a sixth toe, that's called polydactyly. Syndactyly, if you think about the word synthesis, means bringing things together. So syndactyly means that your fingers or your toes are together, so they're webbed together. They can be webbing in between. You also have something called macrodactyly, which is when your fingers or your toes are grow larger than they're supposed to. Sometimes patients are born without a bone that's supposed to be there, which is another congenital deformity. I had a friend whose grandson was born without his femur. So when he was born, he had a normal right leg, but his left leg, his femur never developed. So he had to go through a lot of surgeries repeatedly until he reached his full height, adding rods to the leg to help him to walk. And he had to learn how to rewalk every single time. Sometimes patients are born with the bones out of place or in different positions. So I remember a few years back on, I don't know if it was America's Got Talent or one of those, it wasn't American Idol, it was one of the other shows, but there was a young girl who was born and her arms had actually been, the joints were flipped backwards so that her elbow was not on the back of her arm, it was kind of on the front. And so her hands had also formed into contractures. So she couldn't really use her hands either. So sometimes in utero, which is very rare, the bones are formed abnormally. They're dislocated abnormally. The bone may be completely missing, or it may grow in a different position than it should. Osteogenesis imperfecta, what's that? Anybody know? Osteogenesis imperfecta. Brittle bone disease. So have you all ever seen Glass, the movie Glass? Anybody? So the character, Samuel L. Jackson's character in the movie Glass, had osteogenesis imperfecta. So it's not just brittle bones. The bones don't grow properly, and so they're very fragile. And we typically, like Sonia said, diagnose this in children very early. Sometimes if their osteogenesis imperfecta is severe enough, their bones can break during delivery. So just the sheer force of coming through the birth canal can break their bones. And in the case of the man from Samuel L. Jackson's character in Glass, that's what happened. When he was born, he was so deformed because his bones were so fragile that they had broken. All of his bones have broken during delivery. Chloe, you should absolutely go watch it. You have to watch Glass, but it's part of a trilogy. So you have to start with what's the first? So Split's the third one. Unbreakable's the first one. There you go. Unbreakable first, then Split, then Glass, and then Unbreakable, then Split, then Glass. So you have to watch them in that order. I don't know if it's on Netflix. I think it's on the HBO app. I watched all three over Christmas break. All right. So osteogenesis imperfecta, very fragile bones. It comes in stages. So for some kids, they're just more fragile. They can participate in normal activities. For other children, they can't participate in anything, and they're confined to a wheelchair because just the weight of their own body can lead to severe fractures and breaks in their bones. Oftentimes when OI is diagnosed, it's misinterpreted as, or misdiagnosed as, child abuse, because the bones will often be in various stages of healing because the child's bones break so easily. And so people will assume that you're beating your child or you pushed your child down the stairs, when in reality, they just took a normal fall that any child might take, but broke their femur because they have this disease, especially if they're not diagnosed during delivery or at delivery or in the newborn stage. It's often misconstrued and misdiagnosed as child abuse. Dysplasia of the hip can happen when the infant's hip or the newborn's hip can pop out of place really easily, so it doesn't grow in place or develop normally. So if you have kids and you've ever been to when you go to their newborn appointment and it looks like the doctor's hurting them because they literally grab both legs and kind of bend them up, flex them up as much as they can, and then they rotate them out really, really far to see if they're going to dislocate. Because oftentimes these kids with hip dysplasia, it'll pop out of place. They kind of flip the babies, yeah. Let's see. How would you ask questions about that to determine? So really, you ask all the questions that you would normally ask to assess for abuse. You try and because you have to rule it out. Of course, genetic testing will reveal that the child actually has osteogenesis imperfecta. But you would have to ask all of the typical assessment questions to determine whether or not the child has been abused, and then get the genetic testing to determine whether or not they have osteogenesis imperfecta. Oftentimes you can tell in utero because the baby doesn't develop quite normally, and so the OB will look for those things. Some of the testing that they do, like the amniocentesis, they do those genetic tests, can reveal osteogenesis imperfecta during the fetal stage now. So it's less common to misdiagnose it or to miss it as it used to be a long time ago. And then what is a club foot? It can affect both one or both feet. Has anyone ever seen a club foot? See if we can get this picture pulled up. It does kind of look like a golf club. It does look like a golf club. Wait, did you all do this lecture in patho, in the first patho class? Chloe, you said you saw this in patho 1. Have y'all done this already? This content? Seems familiar. Shawana said yes. Okay. I may be wrong though. It doesn't look like you're wrong. Everybody else close said you don't remember. All right. Well, we're gonna go through it, and hopefully this means that it's a review and you'll do great on these particular questions. So we're gonna keep moving. So a club foot, basically, it is that a deformity that the baby's foot, that foot joint is rotated so that their foot kind of it resembles a golf club. So the issue for these kids is that they'll often need inserts or special shoes. They may have difficulty walking, and may need surgery later to help loosen up those bones. So we treat club foot within the first few weeks of life. Hopefully, a lot of kids can be helped with casting and serial manipulation, so physical therapy without having to do surgery. But if the deformity is really severe, or if we do the casting, we do the physical therapy, we go through all of this and the deformity stays, then we may have to do surgery. Osteochondrosis are diseases where the bone growth centers start to degenerate or necrose and have inactivity. And so you can imagine if you have necrosis of your epiphyseal plates and the epiphyseal center of the femur, the child's not gonna grow. Yes, Chloe, sorry, to answer your question, it's rotated inward so that it resembles a golf club when you look at it. And I had a picture pulled up and then moved on without showing you. So hold on one second. So here's an image, a couple images actually, of club foot. So you see this joint here is kind of rotated inward so that it resembles a club. And then you also have these images here that are much more severe than the one in this picture here. So this is a much more severe case. So this child may require surgery. They may not be able to use physical therapy to manipulate that and straighten it out. All right. Well then, Stanley, if you all did this in first semester, then you should be teaching me, right? You should be able to teach me. Osgood-Schlatter disease is where the patient gets little microfractures around the patellar tendon, and the femoral epiphysis gets damaged as well. So again, you can see how it would lead to both pain and difficulty with mobility. What's scoliosis? What is scoliosis? It's an abnormal curvature of the spine. So we can have just a mild scoliosis where it's just kind of rounded and the normal curves are just slightly exaggerated, or you can have a full S curve where the whole back is twisted. Sometimes you don't see it when this child is standing up, and you don't necessarily see it when the child is older or younger, but as they get older and the spine lengthens, it's more pronounced. So like my 15-year-old who's 6'1" now has had some mild scoliosis his entire life, but we didn't notice it until he got to about 5'11", that that curve is actually causing one of his hips to be slightly higher than the other, and it's caused tightening of all of his leg muscles so that he gets his Achilles gets very tight and causes pain in his lower legs and in his calves. So he has to stretch every single day. He does yoga every day, every morning before he goes to school, and every night before he goes to bed. He stretches to prevent those muscles from staying so tight so he doesn't have the really bad back pain. A lot of people's that's how you notice, is because they're holding their shoulders at different angles, or sometimes we don't see it until we have them bend over. So as they bend forward, we're looking to see the curvature of the spine, and one of their shoulders drops just slightly, and we can see the abnormality when they're bent over. So that's called postural scoliosis, where you see that small curve that corrects when they bend over. You see the curve when they're standing, and then when they bend over, the curve goes away. Structural scoliosis, the deformity doesn't adjust after with bending, so it's still there. But with postural scoliosis, when they bend over, it goes away. Yeah, so Chloe, that absolutely can happen. It can make, so depending on where the curve of the spine is, can determine whether your hips are more affected, or if it's the shoulders where you notice the abnormality. So if it's a higher curve, if the curvature, the abnormal curvature is higher, then it can cause the scapula to be more uneven. Whereas if it's more of a lumbar curve, it can cause the hips to be more uneven, and the shoulders may not be as affected. And so that'll also determine where the pain that they experience is. So with my son, it's his lower back where he has the pain. But with some people who have a higher curvature, they have neck and shoulder pain because those muscles of the shoulders are pulling really tight. And so it's causing tightness in their shoulders, which can also lead to headaches as well. So classifications of scoliosis and what determines the difference. Idiopathic means there's no real cause that has been established. It's just a structural abnormality. Congenital scoliosis is when there's a problem with embryonic development. So you can see it during like a fetal ultrasound or something like that. And then neuromuscular scoliosis happens because you have a muscle or a nerve problem. So you've got damage that causes changes to, oh, am I not? I thought I was. Hold on, let me try again. Y'all, Blackboard is killing me today. So we've got idiopathic, which has no known cause, which is, what we see in a lot of people. Congenital scoliosis is a problem with embryonic development. No, thank you for reminding me. And then neuromuscular scoliosis means there's a nerve or a muscle problem. So damage to the nerves or muscles that causes weakness. And because of the weakening of those muscles or those nerves, the spine can't be held in place very well anymore. And so then the scoliosis develops. So what is equilibrium? What is equilibrium? Balance, exactly. So things that help us to maintain equilibrium of the bone tissue or balance of the bone tissue is mechanical stress. So where the stress is on our body. So how we stand, how we sit, how we walk, where how strong our bones are and how much stress we put on our bones can affect the equilibrium. And then the things that affect bone health can also affect its equilibrium. So the uptake of calcium and phosphorus, we talked about that with electrolytes, how calcium and phosphorus are necessary for bone metabolism and bone growth. Hormones and human growth hormone and other hormones that help with bone growth, as well as cytokines that are necessary for healthy bones as well. All right. What's osteopenia? And what's the difference between osteopenia and osteoporosis? The difference between osteopenia and osteoporosis. All right, so bone loss versus fracture. We've got destruction of the bones. Osteopenia is a reduction in bone mass. So it can be less bone formation, it could be poor bone mineralization, or it can be deossification, so breakdown of the bones, calcium reuptake from the bones. Or we also have osteoporosis, which is loss of bone mass and deterioration of the architecture of the bone. And so then the bones become more fragile and susceptible to fracture. So osteopenia, bone loss, can lead to osteoporosis, which makes the bones more fragile. So you've had so much loss of bone tissue or bone mass that now the bones can fracture easily. And a lot of things can lead to osteoporosis. We know it's more common in Caucasian females, particularly those with very small bone structures, especially those who are postmenopausal. And you have an increased risk if you had a family history of osteoporosis as well. We also know that increasing physical activity improves bone health. So sedentary lifestyle, not getting enough calcium, eating a very high protein diet, drinking excessive alcohol and caffeine, as well as smoking can demineralize your bones. So one of the things, the research that came out several years ago was that dark sodas like Pepsi and Coke, when you drink those, it actually leaches calcium from your bones and increases your risk for osteoporosis. So, one of the jokes we used to make when I was in nursing school was, well, maybe we should all switch to Mountain Dew. Well, the problem with Mountain Dew is that it has lots of other chemicals in it and has been linked to infertility in women. So you don't want to do that either. So my solution is just to not drink soda at all. It's bad for you. But we also want our patients to get exercise and to get a lot of calcium. So one of the things that we know is that a lot of times females wait until they're postmenopausal to increase their calcium intake, but really the time when the calcium gets deposited and retained most readily, when it's most important for you to get calcium, is in your 20s and 30s. So you want to make sure, for you all who are, you're in your 20s, you're in your 30s now, make sure you're getting your calcium in now to protect your bones later. There are also some medications and disease processes that can cause osteoporosis and leaching of the calcium from the bones. Particularly cancers of the bone can lead to weakening of the bones and those fractures that we tend to see. So here are our diagnostic tests and our treatment for osteoporosis. So make sure you pay attention to this slide with your treatments and your diagnostics as well. So we want to do bone density testing. We want to get x-rays to look at the absorption or the uptake of the bones. And then once we have diagnosed using the x-ray and the bone density testing, we want to increase the patient's exercise, make sure they're getting enough calcium in their diet. So that's our prevention. But we also want to increase their weight training, weight bearing exercise. So a lot of females are often focused on cardio as well, but we know that weight training is a good way to maintain both bone and muscle mass. And then, of course, we can give them medications that help with the reuptake of calcium and prevent the leaching of the calcium as well. So we talked about osteopenia. We talked about osteoporosis. What is osteomalacia? Similar but different. Osteomalacia. So it's a softening of the bone. So with our osteoporosis and our osteopenia, we're losing bone mass and we're losing the cancellous bone cells or architecture of the bone. With osteomalacia, the bones don't mineralize adequately. So usually it's from a deficiency of the nutrients or the minerals that are required for us to have healthy bones, like calcium or phosphorus. So either of those that are deficient can lead to osteomalacia or a softening of the bone. Rickets comes from a vitamin D deficiency. So because vitamin D helps with calcium absorption and with mineralization of the bone, if patients are lacking in vitamin D, then they can develop rickets, which can cause softening of the bones and bending of the bones. So if you've ever seen like pictures of pirates and people who've worked underground for years, and they have the rickets can lead to that genu-varum, and that softening of the bone leads to the bending of those bones, so that patients don't have abnormal mobility, and it's all because they're lacking in vitamin D and can't absorb calcium appropriately. So it makes their bones softer. Exactly. So we see this in poverty-stricken areas, not so much in the United States anymore, but in other areas where patients get inadequate nutrition or nutrients. We often will see this because we'll see both osteomalacia because there's a lack of calcium and phosphorus in the diet, And we'll also see rickets because the patients have inadequate calcium absorption and lack vitamin D. Paget's disease is excessive bone destruction and repair. So the body breaks down the bone and then it builds it back up. So what does Paget's disease come from? Where does it come from? What's your book say? It is more common in Northern Europe or those of Northern Europe, European descent. So it's really just an abnormality in, it's like it's often genetic. So the body breaks down the bone and then replaces it more quickly than it should. We diagnose it using x-rays and blood tests and bone scans that show the pattern of that constant recycling of bone tissue. And so we treat it by making sure the patient gets enough phosphate. So we give them oral phosphates, supplements, monitor we want them to get good exercise, to make sure that they are keeping their bones healthy. But biophosphates are the most common treatment for Paget's disease. Which of the following conditions results from loss of bone mass? Bone mass. Osteomalacia, osteoporosis, rickets, or osteopenia? I'm gonna not agree with that one. Yeah, it's B. It's B. I mean, it's D, osteopenia. Osteoporosis is excessive bone loss of bone mass that causes a weakening or fragility of the bones. All right. Let's talk about activity intolerance. What is activity intolerance? It's fatigue, right? The patient fatigues quickly with activity. They're tired after they work. They do some work, they do some physical activity, and they're very tired. Oftentimes, we see this in patients who have chronic fatigue syndrome, but also myalgic encephalomyelitis. Myalgic means muscle pain, encephalomyelitis. So if your patient has myalgic encephalomyelitis or chronic fatigue syndrome, what are your clinical manifestations? What do you expect to see? So we may have some muscle pain, some weakness, feeling tired for more than 6 months typically. So they'll have muscle pain and joint pain. They'll have a difficulty exercising and just feel kind of overall weak. Um, if it progresses, they may even complain of some confusion or lack of concentration. They may be overly sleepy. They may have some anxiety, and because of all these physical changes, it can cause some mood issues with like depression um and that type of thing. They may be overweight, but not necessarily. Their problem is not it's not because they don't exercise. Their problem is a physical issue with the muscles and the nerves. So we treat this, a lot of times this can be misdiagnosed as just depression. Have you all ever seen, do you all watch the Golden Girls? Does anybody watch the Golden Girls? It's like my favorite show. Shawana, you don't watch the Golden Girls? What? Does anybody watch the Golden Girls? Did you just call me old? I think you just called me old. Oh my goodness. I love you anyway. I feel old sometimes. I know, I'm just kidding. So there's an episode of the Golden Girls where Dorothy's a really tall one. For those of you, I know if you haven't watched it, you've at least seen the characters. So Dorothy is the really tall one. She's been tired, just feeling weak, not wanting to do anything for like 6 or 8 months, and she goes to the doctor and he blows her off. She goes back to the doctor and he blows her off. Basically just tells her she's getting old, tells her she needs some antidepressants, maybe she needs a man or something like that. Just need a vacation. So she goes to a specialist. She leaves Miami and her lanai, and goes to New York to see a specialist. And that specialist diagnoses her with chronic fatigue syndrome, basically a neurological disorder that leads to the muscles and the body being physically tired. And so it is treated in some cases with antidepressants if the patient has also developed some mood disorders, because they're so tired all of the time, it's affecting their normal function. They have difficulty and just maintaining their mood, so they can end up with some depression because of how much it disrupts their normal daily function. So we also teach them to manage their stress, relaxation techniques, exercise, getting on a routine, making sure they're getting a healthy diet, and oftentimes just physically changing those basic lifestyle choices, diet, exercise, rest, can put their condition in remission. So we need to make sure that we are getting good, giving them good information. What lab tests might we get for chronic fatigue syndrome, or ME, myalgic encephalomyelitis? Are there any tests you think that we could get, or what does your book say? I still can't believe y'all don't watch the Golden Girls. What are some lab tests? Thyroid, exactly. So we want to rule out other physical disorders like hypothyroidism. We want to get an H&H and see if maybe that fatigue is coming from anemia. Absolutely. What about, we're talking about bones and muscles, which electrolytes do we want to check for that could cause weakness in the muscles? Potassium, calcium, and phosphorus. We just talked about phosphorus as well. A CBC, H&H. What is an ESR? Vitamin D, also, Sarah, absolutely. And to go along with the H&H and looking for anemia, we also want to get an iron level to look for iron deficiency. What's an ESR, or an erythrocyte sedimentation rate? It checks for inflammation, absolutely. The more accurate test for inflammation is the C-reactive protein, but if that's not available, some labs don't run that test. We can do an ESR to check for inflammation as well. And then we'll also do probably a urinalysis to check for any type of kidney issues and renal infections, kidney infections. We may also look for autoimmune disorders. So we might check for possible antibodies or IgE levels that could indicate autoimmune disorders. But basically, the lab testing is all focused on ruling out other conditions that lead to similar symptoms, like the thyroid issue, like the anemia, like the rickets, or one of those other diseases that can lead to muscle weakness, or like lupus, for example, or Lyme disease. Arthritis, rheumatoid arthritis can lead to similar types of symptoms as well. All right, so that is a review, apparently, of bone musculoskeletal disorders, or disorders of the function of the musculoskeletal system. So let's take a 5-minute break, 8-minute break. We'll come back at 5:40 and we'll finish up chapter 50, which is only 50 slides, but that is also disorders of the musculoskeletal function, but with a focus on rheumatic disorders. So before we take our break, are there any specific questions about this content? I know now, I know that it was a review for you all. So hopefully this particular test will be easier. But are there any questions? I know it's late in the day and everybody's you're welcome, Sarah. I know it's late in the day and people are brains are starting to get tired, like my internet or Blackboard is right now. So any other questions? Make sure you know what the diseases are and what the causes of the diseases are. So the definitions and the causes, as well as some of the treatments. For most of these conditions that we just talked about already, the cause has to do with lack of minerals, whether it's calcium or phosphorus, vitamin D deficiency. So if you're lacking in something, we're going to fix it by giving it to you. So the treatment is going to be supplementation, as well as activities that build muscle and bone health. So exercise, weight training, cardio, diet. All right. If there are no questions, then we're going to take a break until 5:40. Well, let's do 5:45. We'll give you a full 10 minutes to take a break. So stand up, move around, grab a drink, grab a little snack real quick, and we'll come back at 5:45 and finish up our last official lecture of the semester. Can y'all believe it? We're only like a couple weeks away from the end. Whoa. Whoa. All right, we'll be back.
Can you please tell Bufa to come? Bufa now, wow. Okay. Tell her I've been waiting for her since 30 minutes. Okay. Thank you.
Bye.
Mm-hmm. Hello? Hello?
Mute your camera. Sorry, your what's it called?
Yeah, I'm talking.
I work at the National Defense Office, so this supported it, the osteocycle and to support it.
All right, I'm back. Can you all hear me? Awesome. Thank you, Stanley. All right, so now we're going to focus on rheumatic disorders. Did you all go over rheumatic disorders in Pathoform 1 also? Yes, no, maybe. Wait, I got a yes and a no. No, no, no. Okay, we'll see. Uh, we'll go through them. We'll go through it now. So basically, we're talking about arthritis. Rheumatic disorders basically refers to arthritis. So in primary arthritis, it's conditions that it results from an immune response. So basically, your body attacks itself and leads to degeneration, um, and affects other body systems. It can affect other body systems in addition to the musculoskeletal system. Secondary arthritis is typically limited to a single joint and comes from a degenerative process related to use of the bone. So you can see that, you develop arthritis in one knee. I developed arthritis in my right thumb joint, strangely, just from typing and writing and things like that and overuse of the joint. Um, so that's secondary arthritis. Primary arthritis typically involves the entire body or multiple body systems. Secondary arthritis is usually relegated to a single joint or a few joints. So just the hand or just the knee or just the back. So we have different types of rheumatic diseases, autoimmune diseases, rheumatoid arthritis, lupus, sclerosis, systemic sclerosis and scleroderma, polymyositis, and dermatomyositis are the ones that we're going to focus on. So rheumatoid arthritis is associated with articular manifestations and extra articular. So things that don't have to do with the joints and the articulation of the bones and the movement of the bones. So rheumatoid arthritis can affect multiple body systems, not just the muscles and the joints. Typically, when patients are diagnosed with rheumatoid arthritis, their problem is not that their fingers are starting to contract or that they're having pain in their knees. Their manifestations are more like what we saw with what you see with lupus. They're systemic, so they're fatigued, they lose appetite, they start to lose weight. They're just generally achy and stiff, not having pain or stiffness in a specific joint. Rheumatoid arthritis has exacerbations and remissions, and it can be due to different things. So some patients have exacerbations when they get very cold. Some patients have exacerbations when they get sick. Anything that can diminish your body processes and affect your overall body processes can lead to an exacerbation. It can also affect just a few joints for brief duration. So like my father has rheumatoid arthritis rheumatoid arthritis that he developed when he was in the Navy, and it only affects his hands. So he has the joints in his hands. He gets the overall fatigue and anorexia and stiffness in his entire body, but he has worse pain in his hands when he has those exacerbations. Systemic autoimmune rheumatic diseases are those chronic disorders that lead to inflammation throughout the body, or lesions and inflammation and degeneration of the connective tissue that we have in our joints throughout our body. So they're going to have similar clinical manifestations amongst them all. So they're all going to kind of present similarly, but when you do the testing, it'll tell you which disease you're actually dealing with. So patients with rheumatoid arthritis, we talked about they're tired, they're fatigued, they have weight loss and anorexia, and they ultimately have pain. So we want to help improve their symptoms. We can't cure the disease because it's the degenerative disorder. It's not going to go away, but we can help to minimize the symptoms. So we want to decrease the pain by giving them pain medication. We want to decrease the stiffness and swelling by having them do stretching exercises and movements. We want them to stay as mobile as possible and prevent worsening of those joints. And we really want them to have a good understanding of their disorder and what causes exacerbations or triggers exacerbations for them, and what to avoid and what activities work for them. So you'll see a lot of patients with rheumatoid arthritis. There's been a lot of research done on how yoga and meditation can help them. A lot of them will use like CBD oil for their pain because that also helps with inflammation. CBD oil tends to decrease inflammation as well. So that can help them in addition to the other pain medication. So I just saw Dane's okay, so I do remember us having a conversation, sidebar, for a second, guys, about the fact that you all had content on the final that you didn't get a lecture for. And so it was just okay, so that was this. So good. So I'm glad we are going through it. It's gonna be helpful then to leave it in. All right, let's see. So rheumatoid arthritis, the criteria is based on the amount of symptoms and the amount of joints that are affected. So they may have morning stiffness for at least 1 hour. For at least 6 weeks, they can be diagnosed with rheumatoid arthritis. Swelling of 3 or more joints for at least 6 weeks could be diagnostic of rheumatoid arthritis. Swelling of the wrist, metacarpal, phalangeal, or proximal interphalangeal joints for 6 weeks or more. So that's basically the hand and wrist. So some of you are old enough to remember the O.J. Simpson trial. Do y'all remember? Anybody remember O.J. Simpson and that whole ordeal when his wife was murdered? So during the trial, one of the defense attorney's famous lines was, "If it doesn't fit, you must acquit." So one of the he was talking about O.J. Simpson's gloves. So they found a pair, well, not his gloves, but the gloves that were found that had Nicole Brown Simpson's blood on them, I think. And so when O.J. Simpson went to put them on, his hands didn't fit into the gloves. They were too small. Well, fast forward several years later, and he puts out a book, if y'all remember, a few years ago, called If I Did It. And so one of the theories that comes out in this book is that O.J. Simpson has rheumatoid arthritis, and it causes swelling, this swelling that we just talked about of the wrist, the metacarpal joints, and the proximal interphalangeal joint. So it causes his hands and fingers to swell. So the theory that's presented in the book is that he stops taking his anti-inflammatory medication for his rheumatoid arthritis, which allows his hands to swell so that they no longer fit into the gloves. And so the theory that is posited in his book is that because of rheumatoid arthritis, he was able to be acquitted because the gloves didn't fit because he stopped taking his medication. So he used it to his advantage. So funny little tidbit piece of trivia that is actually very relevant to what we're talking about. Because when our patients stop taking their medication, it leads to a return of that inflammation and that pain that they've been experiencing. And so they need to be aware that they need to continue their treatments and that the rheumatoid arthritis is not going to go away. We can help minimize their symptoms, but we can't cure their disease. When our joints begin to destruct, they become unstable. We have problems with mobility. It can also lead to dislocation and misalignment of the bones, which can lead to pain. So any of these conditions that are progressively destroying the joints, like our arthritis, it can lead to subluxation, the joint becomes unstable, and we have decrease in movement. So that can come from arthritis. So let's say you have one common cause of arthritis is particularly if we have a secondary arthritis, you'll see it oftentimes in patients who are obese and they have a lot of weight on their knee and hip joints. And so that causes damage to the cartilage in between their bones, and basically it wears away so that their tibia and their femur are rubbing bone to bone and causing pain. So that joint gets destroyed. So when you see that, you understand what they complain about is pain in that joint. Their knees kind of feel weak. They have decreased movement. They can't bend their knees as well. You hear them grunting when they go to sit down or have difficulty bending their knees to climb the stairs because of that destruction of the joints. We can also see a secondary arthritis from trauma sometimes or necrosis of the bones. And so that can also lead to degeneration or destruction of the joint as well. I had a cousin who was in a car accident and broke his femur, which damaged the blood flow to his femoral joint. So that the head of the acetabulum started to deconstruct or destruct because of lack of blood flow. And so his hip would often sublux or dislocate because of the misalignment of that bone, because now that acetabulum that's supposed to fit snugly into the pelvis is starting to wear away and it's too loose. So he has severe pain. He has frequent dislocation of his hip joint and then ultimately decrease in movement, which oftentimes with secondary arthritis, the only way to fix the problem is to replace the joint, whether it's a shoulder, a knee, or a hip. We just replace the joint. So other symptoms we talked about already of rheumatoid arthritis. Because of the inflammatory process, they also might have a fever. So that's also very common to see in addition to the other symptoms. Lupus is another connective tissue disorder. Our body forms antibodies against itself and causes chronic inflammation and issues with the connective tissue. So clinical manifestations of lupus are similar to what we saw with RA. So our patients are tired, they're fatigued. The classic symptom, classic sign, primary presenting sign for lupus is a red butterfly rash across the face. So their cheeks and the bridge of their nose are red and the rash forms the shape of a butterfly. Over time, though, we see inflammation of the skin, we can see heart damage, we can see lung damage and sclerosis of the lungs. We also see destruction of the kidneys, as well as sometimes neuropsychiatric disorders that can cause issues with the brain and mood disorders as well. Systemic sclerosis is when excessive collagen is deposited in the skin as well as the internal organs, so they tend to harden because of all the excess collagen. Typically, we see it in the trunk and in the extremities. If it's just the skin, then we call it scleroderma, and it's usually limited to the face and the hands. But oftentimes, systemic sclerosis can affect or cause collagen deposits in the internal organs as well. And if our internal organs are hardened, then we can't, they don't function as well as they should. So then we see whichever organs internally are affected, we will see dysfunction of that body system. CREST syndrome is calcium deposits in the subcutaneous tissue that come through the skin. So we see this in Raynaud's phenomenon. And that is basically we see issues with their hands and feet. We also can see in their lips, particularly when they get very cold, their lips will turn purple, their fingers will turn purple. They lose some of the perfusion to their fingers and toes because they've got all this scar tissue or hardening, these calcium deposits that are preventing their blood flow or normal blood flow. When we have inflammation of the peripheral joints without rheumatoid factors, we have what we call spondyloarthropathies. Spondyloarthropathies. So it's difficulty with or issues with the joints, basically. So this can be reactive arthritis, enteropathic arthritis, you see that oftentimes with inflammatory bowel disease. We can see it with psoriasis. So all of these are autoimmune disorders that are attacking the joints. So that are affecting the connective tissue and the joints. So patients with irritable bowel disease can eventually develop can also have problems with their joints. Or patients who have psoriasis, typically when we think about psoriasis, we think about the skin, but it can also lead to joint pain, which is called psoriatic arthritis. And so we treat that with autoimmune or immune modulating medications that will decrease the immune response. What is ankylosing spondylitis? Does anybody know what ankylosing spondylitis is? Ankylosing spondylitis. It's also known as Beck-Torus disease. Exactly. So it's typically characterized by a curvature of the spine or a loss of flexibility in the spine. And so they develop a hunched position. And actually, what will happen is the cartilage that's in between those vertebrae will collapse at the back or the internal area. And so they'll kind of fuse together to form a curvature. And so the patient has back pain, they have joint pain, they have that hunchback. We can often see that ankylosing spondylitis. We talked about that with irritable or inflammatory bowel disease. I don't know if you all remember that far back, but it was one of the common comorbidities with inflammatory bowel disease is ankylosing spondylitis. Typically, it's going to evolve or present itself in younger adulthood, and we see it more often in males than we do in females. We're going to treat this with anti-inflammatory medications, steroids, immunosuppressants, but also with physical therapy. We teach these patients to stretch and to do yoga, they go to physical therapy, and to exercise. So it's important to make sure they understand the changes physically that they need to make in their lifestyle as well to help maintain their mobility, because it can really be debilitating. So when we talk about problems with the connective tissue and the musculoskeletal system, how do we assess for mobility? What kind of things are we looking for with relation to determining how mobile a patient is? So we want to know exactly. We want to know their range of motion. How well can they move? So we're looking at their range of motion in every single joint, including the neck, including the fingers and the toes, to get a good idea of what the actual cause of their problem is. So this particular slide talks about sacroiliitis, which is basically pressure or inflammation of that sacroiliac joint. So our sacrum, the bottom portion of our spine, connects to the ilium of the pelvis, which causes, and then we have inflammation, and it causes the patient to kind of bend forward, which causes pain and muscle spasms when they move. So we want to measure the distance between the tips of their fingers and the floor when they're in a bent over position with the knees straight. We do a modified Schober test and look for flexion of the back from side to side. So how well can they flex or move their back from side to side laterally? And then we also want to measure for chest expansion, which will tell us whether or not the rib bones are also abnormally have issues with their mobility or with inflammation in those connective tissues as well. So is there any thoracic involvement, or is it just the sacrum? Reiner disease has the same clinical manifestations as reactive arthritis. So it also has symptoms outside of the joint. So we see problems with the eyes, we see inflammatory bowel, we see inflammation of the heart. So it can cause inflammation in lots of other body systems, and it typically develops after a chlamydia infection. We can also see it in salmonella, campylobacter, things that cause gastroenteritis that leads to this inflammatory process in the body. So it's basically just a genetic reaction to these disease processes, these bacterial infections that lead to arthritis and inflammation throughout the body. So again, psoriatic arthritis is when those people who have the genetic makeup for psoriasis also develop arthritis as a result of that antibody formation and the attack on the joints. So we're going to see decrease in their articulation. It could be asymmetric. We're going to see changes in their spine. We'll see we have polyarticular or symmetric, so multiple joints, specifically the distal finger joints or distal toes also. So here are your most common causes of osteoarthritis. So what we typically see in older adults. So it can come after an inflammatory disease. We just talked about that with Reiter's disease. It can come after trauma. So I told you all about my cousin who broke his femur in a car accident, and because of the decreased blood flow to his hip joint, he developed osteoarthritis in his hip joint. It can also come from just anatomical changes or abnormalities. So people like me, I developed this arthritis in my thumb joint, and that's because my thumb joint, for whatever reason, is hyperflexing. So I have hyperextension naturally of my thumb joint, and that led to arthritis. Other bone disorders as well, metabolic disorders that can lead to the destruction of bones, nervous system disorders that can lead to the destruction of bones and muscles. If they have a genetic disorder that causes an increased production of collagen that leads to the stiffening of their joints or even the stiffening of their internal organs, that can also increase their risk for osteoarthritis. And then sometimes we just don't know where it comes from. It just develops out of nowhere. So that would be considered idiopathic. Osteoarthritis, similar to the other conditions we've talked about, is degenerative. So it over time progressively gets worse. The primary variants of OA are typically localized, but they can also be generalized as well. Secondary OA or osteoarthritis is going to come from some other disorder or some other condition. So secondary OA comes from trauma. It results after the inflammation. It results after the acquired disease or the destruction of the joint. Primary just kind of comes out of nowhere, and we will see that sometimes in our older adults that just develop arthritis as a normal process of aging. Make sure you know the difference between rheumatoid arthritis and osteoarthritis when you're starting to study for your test. So when our patients have osteoarthritis, we're looking for changes in their joint. So again, it's progressive, so it's not going to happen all at once. Over time, they're going to lose articulation of their joint, so it's just not going to move as well. They might have inflammation of the joints, so swelling and redness of the joints, which leads to pain. They may have bone spurs as well over time. But we know that that joint is going to lose mobility, it's going to lose stability, it's going to be deformed. It's just not going to function as well as it used to because of the destruction and the degeneration of that space. Genetic conditions that some of them that we've already talked about, others of them you can see how they could lead to osteoarthritis. So anything that affects the calcium uptake, anything that affects the metabolism, anything that affects the perfusion of the bones themselves, or anything that leads to repeated trauma or overuse of the joints can also increase the risk for osteoarthritis. Gouty arthritis comes from people who have gout, which comes from an accumulation of uric acid and those crystalline deposits into the joints and the bones. And so one of the primary problems that patients with gouty arthritis have is when they have a flare, they see a swelling in their joints. And typically for one reason or another, it's in that big toe joint that you'll see it most commonly. So the patients will come in complaining of pain in their big toe or severe pain in their foot that also leads to swelling because those uric acid deposits will settle into the joints and cause pain in those tissues, as well as swelling of the soft tissues around the bone. Patients with gouty arthritis are also at an increased risk for kidney stones. They develop uric acid stones. So they take medication specific to gout that decreases the amount of uric acid in their body. Primary gout is typically a problem with metabolism. So they have high uric acid levels. Secondary gout, the high uric acid levels come from some other disease where gout is not the primary cause of their high uric acid levels. So one of the primary things we do when we treat gout, we want to make sure, first of all, to prevent those flares or those acute attacks. So we want to make sure we keep the uric acid levels at a normal range. So we can make sure we adjust their diet and decrease the amount of foods that have uric acid in them. We also want them to be active. And it's important to understand that gout flares are not the same for every single patient. They're going to be very different depending on the person, and the triggers will be different as well. So, I have an aunt who had gout before she passed away. Her trigger was grape jelly. She could not eat grapes or grape jelly because it increased her uric acid levels and caused her to have gout. For some other people, I've heard it's fish can increase their uric acid levels. So you have to figure out the patient's trigger and then teach them to avoid that trigger to keep their uric acid levels down. Juvenile arthritis is arthritis that develops in childhood. It happens typically as a systemic onset, um, and it can affect multiple joints. One of the primary symptoms is joint pain and swelling. These patients may be smaller because their growth plates may be affected, which can then cause them to not grow as quickly as some of their counterparts without arthritis. And children can also present with lupus. Their symptoms are very similar: fever, weight loss, fatigue. It can involve all the same body systems as we saw with adults, but they can also have endocrine abnormalities like Cushing's syndrome that can develop, especially if they are taking long-term corticosteroids. So you all just took a test on Cushing's today, right? Was that you all? I think. Did you all test on Cushing's? Yes. Okay. So tell me, how can long-term use of corticosteroids in these patients who have juvenile diabetes, rheumatoid arthritis, lupus, how can it lead to Cushing's? Exactly. Cushing's is basically excess cortisol, right? So, because they're taking lots of corticosteroids, they're basically giving themselves Cushing's by taking in excessive cortisol levels or cortisol medications for a prolonged amount of time. So, they have symptoms of Cushing's syndrome that the only way to reverse is to stop the use of corticosteroids. And then sometimes they also will develop autoimmune thyroiditis. So the antibodies that developed when they develop their lupus will begin to attack the thyroid. So they basically develop antibodies against their own thyroid, which gives them thyroid disease. Giant cell arteritis. What does that sound like it is? It sounds pretty scary. Giant cell arteritis. What is that? It sounds much more scary than it actually. I mean, it could be a problem, but what is arteritis? Exactly, Sonia. It's just inflammation of the arteries. So if the arteries are inflamed, then we know our patients could potentially have issues with perfusion of their tissues, which is what would lead to the ischemic neuropathy, especially in the tissues that are very sensitive to changes in perfusion, like the eyes. We see arteritis, it's going to affect more frequently the arteries in the head, especially the temporal arteries. So oftentimes you'll see patients tell you they have temporal arteritis, and that can lead them to have severe headaches. Their scalp could be tender. They might have jaw pain. They may have issues with their vision. If it goes untreated, this ischemic optic neuropathy can lead to deterioration of the optic nerve and can eventually lead to blindness. So the manifestations of arteritis or giant cell arteritis will depend on which arteries are most affected. So then which body systems or body tissues are lacking of perfusion. So if it's the eyes that are primarily affected, then we can see blindness. If it's the jaw, the innervation and the perfusion of the jaw, then we can get claudication of the jaw, which basically means the more you chew, the more it hurts, because those muscles don't have proper perfusion, so they spasm when you use them too often because they are lacking oxygen. The same for the arm. And if your temporal arteries are affected, then it can affect your head and give you headaches as well. So what kind of treatments do you think we're going to give or use for arteritis? So our arteries are inflamed. What we're going to give steroids. Exactly. We want to decrease that inflammation. So we're going to give them steroids in high doses to decrease the inflammation. We can also give them pain medication to treat the pain, but the pain is coming from inflammation. So we want to decrease the inflammation to get rid of the to get rid of the pain. All right. So what questions do we have, you guys? That concludes our lectures for the semester. Oh, let's see. Sonia says, can it cause arteries to rupture? So yes, that's a very good question. So because the arteries are inflamed, those tissues are damaged and swollen. One of the common complications of arteritis is aneurysm and stroke from a rupture of those arteries. That's a very good question. So we want to make sure we treat it and reverse that inflammation quickly so that our patients don't have an aneurysm, so that those vessels don't rupture. And you can have a rupture. We typically talk about aneurysms as aortic or brain aneurysms, but you can get an aneurysm in your carotid artery or in your an artery in your arm as well, which would lead to necrosis of the tissue of your arm and prevent being able to use your arm anymore. So any of those arteries that are affected by the arteritis could potentially rupture. We also know that venous or arterial and venous inflammation can also increase our risk for blood clots. Anything that causes inflammation or damage to the vasculature can also lead to blood clots. Pericarditis, inflammation of the heart, all of those things. You do not always give insulin with steroids. If your patient does not have diabetes, then they are not going to get insulin with steroids. You're just going to educate them to alter what they eat to prevent excessive weight gain and hyperglycemia. If, though, your patient is diabetic and either has insulin resistance or doesn't produce insulin anymore, then they're going to need to increase their insulin intake or insulin use while they're on steroids because it increases the blood sugar. That's a good question. Does arthritis occur in women more than men in the hip area or is it the same? So that kind of depends on the type of arthritis and the use of those joints. It's kind of equal depending on the cause. Yes. So I think Sarah emailed me earlier about looking at those quizzes. I'm planning to do that after class, but I agree. There are some that are probably marked incorrectly, and I need to go back and look at those and fix them. You're welcome. What other questions do we have? Anything at all related to musculoskeletal or rheumatic disorders? So next week we will review for the exam. So go ahead and start looking over your material as you can, and come with questions. We'll talk through a lot of the material. No, we are not covering 51 and 52 because you covered those in Patho Pharm 1. So this is our last official lecture of the semester for Patho Pharm. So next week will be just a review. We're going to go over, review the material. You'll have an opportunity to ask any clarifying questions. We're also going to look over the case study practice that you all got last week to make sure everyone understands the expectations for that, and hopefully have an opportunity to go over some practice questions together before exam 3, and make sure that you're prepared for the final. For those of you who are in Adult Health 1, I have already posted the matrix as well as the table that we went through today in the week 14 folder, so you can pull that up and look at it. Blessing says, just to be sure, we are no longer having exam 4. We're combining exams 3 and 4, the content for those 2 exams, and then we are doing the final, which will be in a case study format. And so because I know that Yoel's going to ask me in a minute what chapters, what content is on the exam, let's just go over it. I'm going to be proactive and tell you ahead of time. So exam 3 will cover male and female reproductive. It will cover musculoskeletal that we did today, and rheumatic disorders, which we covered today. So reproductive, male and female, and then musculoskeletal and rheumatic disorders are going to be on exam 3. And then our final will be in the case study format. I will give it to you. I'm going to release it after exam 4 so that you'll have a week or so to work on it before we get to the final. It will be due at noon on the Tuesday of finals week, because that is our time for finals. So to clarify, chapter 40, let me clarify for myself. 43 is disorders of the male reproductive system. So chapter 43, disorders of the male reproductive system. Chapter 45, disorders of the female reproductive system. Chapters 49 and 50, disorders of the musculoskeletal system and rheumatic disorders. So disorders of musculoskeletal function related to trauma, genetics, and structure, and then disorders of the musculoskeletal system related to rheumatic disorders. So 40, what did I say? 43, 45, male and female reproductive, and then 49 and 50, musculoskeletal is our exam. For exam 3. Those are the chapters on exam 3. Exam 3. So next week, let me pull up my calendar. Next week is Adult Health 1, which is on Thursday, April 22nd is Adult Health 1. Thursday, April 29th is Pathopharm Exam 3. And then finals week. When is finals week? What date is the final? Is that the week of the 10th? Is that right? Right. So our final exam will be May 11th. So if we meet during the week of May 3rd, so that Thursday, May the 6th, it will just be a review. Okay. So Adult Health 1 exam is April 22nd. That's next Thursday. Pathopharm 2 exam number 3 is on April 29th. You will get your final exam case study released to you during the week of May 3rd, and it will be due by noon on May the 11th, which is our final exam scheduled date. Is everybody clear on the expectations and the timeline? Awesome. So next week in Pathopharm, we're just doing a review for the exam. So there is not a formal lecture. I will record the review so that you can always go back and look at it and review it before the test. So make sure you look over some of the material ahead of time and come with questions that you need clarified. And hopefully we'll have time to both go over the case study practice and how it's going to be evaluated, as well as go over a few practice questions to make sure that you're ready. Right, Caroline, it's moved up a week so that we have a week for review before the final. Or a week off if you if you want to get your case study done early. So that's why I went ahead and did both lectures today, so we could go ahead and get both of them done and have more time for review at the end. All right, are there any other questions? I want to give you some of your time back. Remember, next week is just review, so come with your questions. For those of you in Adult Health 2, the matrix is posted, as well as the study table that we made today, so you can start using that to build on with your studying. And I hope to have the practice questions posted for those in Adult Health 1 later tonight. All right, well, if there are no other questions, I'm going to let you go. Remember just to shoot me a quick email if you need anything, or if you have questions, either via email, you can post in the discussion forum, or hold them for next week during our review. Thanks so much, guys. I apologize again for all the technical issues today, but thanks for being patient. Have a great weekend.